Okay, how about now?
Yes.
Okay, perfect. I'm so sorry again. I'm teaching Lin and also go by Wally. So a bit introduction about myself. I'm from Taiwan and identify as queer, and my pronouns are he, him, his. And currently I'm working with UBC SARAVYC as a postdoc, and working with LGBTQ2+ study is my passion. So today, I and LSB, we are going to share our studies about girl-to-girl projects. So the first one is about their first-time sexual experience. So a few background is, so according to our lecture review, we found most first-time sex happen during the adolescent period, the young age. So if we could know more about the contact, will help us to promote the sexual health. And also we found most research about first-time sex is about heterosexual girls, at least in the United States studies. And some other information is compared to heterosexual girls, sexual minority girls are at higher risk of HIV and other sexually transmitted infections, and having a higher prevalence of teen pregnancy and sexual abuse experience, and other reasons. So that's why I think it's necessary to know more about the context of first-time sex behavior, then we can promote their sexual health. So these studies, we focus on when, what, and who, and where. So for example, where it might take place, and what happened before, during, and after their first sexual experience. So this studies is under larger studies. So larger studies is about, we want to know bisexual, lesbian girls and their sexual experience, and also their thoughts about preventing teen pregnancy in United States. And we, under the studies, we focus on the focus group. And the focus group, we also have many other questions, but we only focus on their first-time sexual experience. So based on these reasons, 48 cisgender lesbian and bisexual girls involved to these studies, and their age is from 14 to 18, and they live in United States. And they took part in one of 4 online focus groups. So you might wonder why not one-on-one interview, and why we chose online focus groups. So there are some reasons. So I think the first one is, so online focus group is the participants, they only need have their laptop or cell phone, and they log into the platform, and so they can participate in our studies anywhere. So the studies can reach to people that are living in rural areas or some areas. And also, we don't need to worry about the time difference. For example, when you want to schedule the interviews, you might need to think, oh, we have 3 hours difference, so we'll have some challenge. But for online focus group, they can log in and to answer question anytime. And also, it might create some safety and confidentialities. And other reason is if we provide a one-on-one interview, and we probably need to schedule a time and also a location. But some studies might happen in LGBTQ plus center, but when participants they enter to the center, they might worry, oh, am I coming out now? So they might have some concern. So that's why we chose online focus group math. And in our online focus group, it's over 3 days. But we will post the questions twice a day, and the youth can answer a question, and they can visit the online board anytime in the day and answer questions. And moderators will post a question in the beginning of the day and will provide follow-up questions. So the questions we use for this particular studies, including how do you know you have sex for the first time with someone, and what counts for you, and what was the reason you had sex with for the first time. So in our data analysis, we use qualitative description approach. So basically, we will use the whole transcript, but we'll only use the particular questions related to these particular studies. And we will focus on their answers related to their first time sex. And we will read the transcript totally fully, and then we'll reread again, and we will make some notes, and we will generate the result, the topics for our studies. So there are two main results. So one is how they describe their first time sexual partner, first time sex partner. So for participants, their first time sex with girls, and also in a commit relationship, they will use my first, my ex, my current girlfriend, or the girlfriend at the time, and I was in love with a girl. And for other girls, they will say, oh, she was my best friend at the time, and we both have strong feeling for each other. And for girls whose first time sex with a boy in a common relationship, will say, oh, he is my boyfriend and we are in serious relationship. For other in casual relationship, we'll use the guy, the boy, the male. And also some people, when they describe their first sexual partner, they did not use any gender term. So they will use my partner, and we are both commit. If they in a commit relationship, and the person I was with, and for others, they might use my friend and a friend with benefits. And the second result, we want to know the context. So first thing, we want to know where their first time sex happened. So they report two places. One is private, including their home and their sexual partner space. And also they might have their first time sex in public. For example, outdoors or movie theaters. Before their first time sex, they might have some activities before the first time sex. For example, they will walk around watching TV, or they were driving to a place and putting on a movie, or some people they might drink alcohol before or during the first time sex. For example, one participant, she said, I got slightly tipsy at a party, and while in her car on the way back to my place, she asked what would happen if we are to have sex that night, and my reply was positive, and we continued drinking back at my place, and it just happened. So also, some youths they report during their first time sex, um, their partners being in control or report being dominant, or just laying there or let the partner do his things. And one person said, I always say yes, mostly because I was curious and too embarrassed to ask him to stop. So we also want to know their emotions during and after the first time sex. It includes some positive emotion like, oh, I'm having fun. I was feeling romantic. One person said, oh, even though even one participant said it was awkward, very awkward, but we both had fun and it was pleasurable. It also includes some maybe negative feelings like feeling pressured, being in pain, and experiencing regret and feeling scared. And one person said, I want to just get it over with, and that was my biggest mistake. I feel like the biggest slut after that night, and it was mostly due to the stigmas about premarital sex that I let my parents and teachers drill into my head. So, like two other major results, but also we have some comparison based on their identities, and not only about the result, also about the process. Even though we are not in-person focus group, but unlike focus group, we still can see some dynamics. For example, white youth usually were the first to answer a question about the first time sex in every focus group. And only white youth report the location where their first sex happened, and participants from other other groups did not disclose this information. We also find some age issues here. Those youths who are younger at the time mentioned very little about what happened. But for youth that were a bit older, 16 to 18 years old, share some description of what they did before, during, and after the first sex. So I think something we can learn is we know the person they have first time sex. We know what happened before, during, and after. It provides very concrete information to us, and we can create realistic discussion and to help the researcher and professionals to create some intervention or help the youth to make the sexual decision. So that is our studies. Any questions Maybe I can stop sharing my screen first.
I think we'll let people ruminate a little on your presentation and get to questions that you and Elizabeth can answer together after Elizabeth's presentation.
No problem.
Thank you so much, Wally. I'm going to turn it over to Elizabeth.
Thank you. As I think you mute.
Thanks so much, Hannah and Wally. And now I'm going to talk about the broader study from which the paper that Wally shared has come from, and that's talking about Girl2Girl. As Wally mentioned, and as we have seen in our research, actually going back since like the mid-1980s, lesbian and bisexual girls have 2 to 4 times higher risk of teen pregnancy than their straight peers in both the US and in Canada. And I believe there's actually been further research that's happened in other parts of the world that has documented the same thing. This might seem a little counterintuitive, not just that they have like the same risk of pregnancy, but higher likelihood of pregnancy involvement. Despite this, there aren't actually interventions that have previously been created to actually help promote healthy sexual opportunities and sexual decision-making to help young people have intentional decisions around their reproduction, and so that if there is unintended or unwanted teen pregnancy, that doesn't occur. So, as part of a collaboration between the Center for Innovative Public Health Research and our Stigma and Resilience Among Vulnerable Youth Center, CERAVYC, we actually participated in a large project funded by the U.S. Office of the Adolescent Health and the U.S. National Institutes of Health in order to develop and to test a healthy sexuality prevention program for queer girls. And this project was led by Dr. Michelle Ibarra from Cypher. And I was involved, as well as the iconic Dr. Margie Rosario and Dr. Carol Goodnow, who were fabulous collaborators, and of course, a number of our Cypher and CERAVYC research and programming staff. So for those who might want an opportunity to see this further, Girl2Girl.org actually has a website where you can see we've now actually taken this intervention and created it as something that's available for people in the right age group to sign up to and participate in straight from the web. And as we pointed out, as part of that marketing, sex ed is everyone's right. And that's why we created Girl2Girl, a sexual health education program that is just for teen girls who are also into girls. This process involved several stages. The first, as Wally described, was those asynchronous online focus groups that we used to actually develop an understanding of both the phenomenon around sexual decision-making and the reasons people have sex and what counts as sex, but also why queer girls might actually have that higher risk of pregnancy involvement and what they think goes into that, and what that might actually do in terms of guiding a development of an intervention. We also then in the next phase actually developed the text messaging intervention and then started testing the messages that go in. And I'll talk about each of these phases. And then finally, we rolled out this Girl2Girl intervention in a national-wide randomized trial in the United States. So first, capturing the context and words of LGBT girls. And this was specifically focused on cisgender lesbian and bisexual girls in the United States in that 14 to 18-year-old age group. And while the paper that Wally was talking about involved 4 focus groups. We actually had 8 asynchronous online focus groups because another 4 of those focus groups was with girls who had not had any kind of sexual experience yet. So we felt it was important to have like the understanding of sexually experienced young women and the inexperienced ones to think about how we provide an intervention that might be tailored to people's stage in the process. And as Wally said, these were 3-day asynchronous focus groups. You could log in and they'd get new questions each day and they would answer those questions. And part of the group eligibility was also that they had to have cell phones and unlimited data plans because we were trying to understand the group that we would be reaching with this intervention. Now, we've had several papers published from the qualitative information in the online focus groups. They were really quite rich in the information. And so, for example, there's one in the Journal of Adolescent Health about barrier use in girl-with-girl sex, as well as one in the Journal of Pediatrics on the sexual decision-making of lesbian, bi, and pan girls. And then, of course, the first time sex experiences that is published in Psychology and Sexuality that Wally just talked about. The next stage of the process was actually drawing on the information, motivation, and behavioral skills model as the theoretical underpinnings for designing a text messaging intervention to focus on promoting sexual health. And where possible, we actually tried to use not just the ideas, but the actual words that girls used in the focus groups to ensure that the messaging was relevant to the way they talked and the things that were important to them. Now, the challenge of creating messages to address information needs, to address intentions and motivations, as well as key step-by-step information around particular behavioral skills to help with sexual decision-making and to be safe, gets pretty tricky when you're talking about text messaging, because each message could only be 160 characters. And we needed to tailor each of those messages to whether or not someone was sexually experienced or not, and particularly understanding the areas that are both similar and different for lesbian and bisexual girls. So a key part of that work was actually developing the text messaging messages and intervention in order to actually promote that. And another key element is that from the very beginning, we were focused on this being a sex positive approach rather than, as is really common in a lot of sexual health education, focuses more on the dangers and disaster and not necessarily on the pleasures and practices. And so we wanted to ensure that we actually had a sex positive approach to this. Now, before we launched the intervention, we also tested this with a content advisory team, or a CAT, that was comprised of queer girls in the same age group, again, with the ability to have the unlimited data text messaging plans, to see if the messages resonated and actually worked for them, and the wording was right. And that was really a critical moment for understanding how the messages we phrased actually landed and what would be helpful. We covered a bunch of different topics. As you can see, everything about both positive and important health issues, like what unhealthy relationships as well as healthy relationships look like, or how to talk to your partner about difficult things, but also some very key activities and strategies and skills, and the ways that you can focus on sexual health, sort of all the information, and from a lens of the needs of lesbian and bisexual girls who may have sex with a variety of different people, and so may be at risk for sexually transmitted infections or for unwanted pregnancy. A key part of our messaging was that it wasn't just those 160 character like little factoids, but rather some of the messages actually included links to online information. And that included things like, we actually created some animated cartoons for, say, how to use a male condom and cut it up to actually make a dental dam, and then how to use that dental dam. In fact, I did the voiceovers for a couple of these instructional animated videos, which was lots of fun. We also had a text command, Girl to Genie, where you could actually text in a question for specific brief info on particular topics related to the sexual health content in the intervention. And then another strategy that was part of the intervention was actually connecting people with text buddies. So we identified girls who were interested in being partnered with buddies who were in the same time zone, but usually like hundreds of miles apart. They weren't necessarily in the same community. And all of their text messaging went through our software program, in part so that we could monitor and ensure that there wasn't bullying or other things going on. But it was an opportunity, and we had like little cues within the text messages to say, you know, talk with your text buddy about how you might go get tested, or talk with your text buddy about this aspect of relationships, as a way of helping to connect queer girls in similar experiences to provide a little support for each other in the learning process. As two other motivators for the process, we had leveling up quizzes. So after a certain number of messages, there would be this chance to level up, and you could just do a few questions and answer them. And if you got the answer right, you would get a, you know, yay, that's absolutely right, and a reinforcement of that message. If you didn't get the answer right, instead you'd get a reinforcing message that provide the correct answer, and then you would go on to the next level. We also had badges, which were these little icon GIFs that were the little images that were available as sort of achievement markers along the way. Now, as part of doing a randomized clinical trial, we also needed to have a control version of the intervention, or a control group. And so it was essentially creating the same number of texts but instead of being about sexual health and pregnancy prevention and STI prevention, it was about general health topics like nutrition and exercise and sleep and substance use. Now, in order to be blinded to which intervention you were part of, we did also include 1 week of sexual health information that was primarily the same kind of general sexual health information you get from a general sexual health education program, and not specifically tailored to queer girls and their lives and experiences. Now, there are 2 papers that are describing either the program development in all the details of that, as well as part of the evaluation of Girl2Girl, we needed to create surveys that measured the actual outcomes that we were looking at. And so the baseline testing of those surveys, we provided some opportunities for some further deeper dive into quantitatively reasons for sex that queer girls would have with males, or with females, or with others. So as part of the nationwide randomized clinical trial, which was the next thing, first we needed to pilot all of the programming, because this was an automated text messaging intervention, so unidirectional. It didn't actually engage in back and forth. We just pushed out the text messages, and then people could connect on the links, or they could text Girl to Genie, or they could engage with their text buddy. But the intervention basically was unidirectional. So we needed to make sure, because it was all very complexly programmed into the technology, that it actually worked. And as you might expect, there are always a few hiccups along the way, and so we needed to test it out. We also needed to develop specific outcome measures that would align with the informational, motivational, and skills, or behavioral skills model, and were specific priorities for our funder in the Office of Adolescent Health. So that was looking at particular outcome measures for the this intervention, and then we implemented that survey pre-intervention, and then follow up at 3, 6, 9, and 12 months of the intervention. And we recruited girls the same age as in our online focus group, 14 to 18-year-olds in the United States with an unlimited cell data phone plan. And as part of this, we did receive a waiver of parental consent, because as you might expect, not all queer girls are safe to be able to engage their parents in understanding that they're sexually active or that they're part of this kind of an intervention. They may not even be out to their parents. But we did have, as part of this consent process, an assessment of their knowledge and ability to actually understand the risks and to be safe in participating in this intervention. Now, the actual intervention involved 7 weeks of 6 to 10 text messages each day about various topics that were related to sexual health and relationships. And if you think like, wow, 6 to 10 messages is a lot. Actually, the typical adolescent girl gets on average between 30 and 40 text messages a day. So 6 to 10 is actually just part of the mix, and it's not really too much. We also did have a feature, though, in the intervention where if you actually wanted to pause the messages or to schedule them to come only at certain times of the day, like not when you're in school, you could actually program that or request that in the system so that it could be set up that way. So after those 7 weeks, then there was 3 months of a latency period where there was only like 1 to 2 messages each week to sort of remind you that we were still there. Then we had one last booster week that had 6 to 10 messages a day again, each day covering different topics that were part of those 7 weeks. As I mentioned, there was that pre-intervention survey, then online or cell phone text messaging surveys at the end of program, and then at 3, 6, 9, and 12 months after the end of the program. And all of our analyses of the outcomes were based on intent to treat. So regardless of whether you actually got all of the intervention, whichever group you were randomly assigned to, that's where you were expected and where your data was included. And we used mixed effects models to address that sort of repeated measures and to control for baseline status. So we had 948 lesbian and bisexual girls who were randomized to either the Girl2Girl or the control group. And at the end of the program, we had better than 80% follow-up. It's about 83, 84% follow-up in both groups, which is really quite amazing. At baseline, we had only about a third of the girls had ever had penile vaginal sex, but about 1 in 4 were currently on birth control, and 3.5% had been pregnant before. The primary outcomes that we were looking for, and most of these were measured at in the past 3 months, whether or not you'd had sex or not in the past 3 months, how many sex encounters you had that actually involved condom protection, whether you were currently using birth control, whether you'd gotten pregnant since you started Girl2Girl, and changing your intentions around using condoms or birth control, or being abstinent or not having sex in the future. So we published the early results, that is the results from the intervention just as it was finishing after those 20 weeks. So remember, 7 weeks, then there was a 3-month break, a final week, and then we did the early results. And what we found was that compared to the girls in the control condition, girls who participated in the Girl2Girl intervention had higher rates of condom protected sex, significantly higher current use of birth control, higher intentions to use birth control in the future, and although not statistically significant, a clinically significant reduction in or lower rates of pregnancy, less than half. There were not very many pregnancies that occurred within the groups, and so that is one of the things that we wonder if perhaps part of that is just that relatively rare occurring event. Abstinence, however, was not different between the groups, and we weren't particularly surprised by that because this was not an abstinent-only kind of intervention. We were really sex positive and looking to provide a variety of information to help with young people's decision-making. So I'm here to give you a sneak peek at our longer-term results, which are not yet published. We're in the midst of writing them up, but we actually have had the opportunity to do the analyses around the 3, 6, 9, and 12-month outcomes. Again, with those mixed effects models that control for your baseline characteristics and that sort of repeated measures over time. And we find that, in fact, that higher rates of condom-protected sex that we found immediately at the end of the intervention continued and were significantly different at 9 months and at 12 months. In fact, compared to what is more typically the case, that you see sort of attenuating effects over time after an intervention stops, we actually see increasing rates of higher numbers of condom-protected sex as you get further along from the intervention, which is really intriguing for us because that's not as typical. We also see higher rates of people who are more likely to use birth control compared to the control group at 6 months, 9 months, and at 12 months. There you see the typical attenuating effect, which suggests might need a booster somewhere along the line. However, abstinence and pregnancy were not statistically significant at any of those time points. However, pregnancy effects, the effect sizes for pregnancy were in the right direction among girl-to-girl participants compared to their controls. That is, they had lower odds of reporting having been pregnant since the beginning of the RCT compared to those in the control groups. So clinically promising, but again, very small numbers. So this is a first in the field because this is the first teen pregnancy prevention intervention for queer girls that's been tested with a large national RCT. And I think the first that actually has 12-month post-intervention outcomes. So this is long-term follow-up, which is great. We also see some really impressive effect sizes for this type of intervention and for the persistence of those effects over time. In fact, an editorial was written in the journal Pediatrics that provided those short-term outcomes where the editorial was commenting on the unexpectedly impressive effect sizes of this intervention. We see that this particular type of approach, that is the text messaging approach, actually has the benefit of reaching teens where they are, including reaching rural youth during the COVID lockdown, if there are restrictions on meeting in person. As well, it provides that confidential information and that chance to participate without having to go somewhere and be identified. And so that provides a very confidential opportunity for young people. So in looking at the work that we've done, next steps, the Girl2Girl was only for cisgender girls because we recognize that trans and non-binary young people would have different kinds of perspectives and health issues and ways of talking about sexual decision-making. So as part of the NIH funding, we did actually conduct 8 online focus groups with trans boys and non-binary youth. And we are in the midst of doing analyses of those as a collaboration, again, between Cypher and SARAVYC. And our goal is actually to tailor this program for trans and non-binary young people as well. We're writing the grants to see if we can get funding to make that happen. And this was research that's done in the United States predominantly. And while our pregnancy, adolescent pregnancy levels in Canada are quite a bit lower than in the United States, in part because of our ready access to sexual health education and sexual health care and access to contraception, et cetera. We still do see that lesbian, gay, and bisexual young people in Canada, as well as trans and non-binary young people in Canada, have either equal rates or higher rates of teen pregnancy than their heterosexual and cisgender peers. So we're looking at the potential to adapt the intervention to the Canadian context. We're looking to secure funding to pilot this and then roll it out across the country the way it's happened in the United States. So thank you for listening to our presentation. I will stop sharing now and create the opportunity for if you have any questions.
Thank you so much, Elizabeth. This was fantastic. As people are sort of ruminating and thinking about getting their questions in the chat, I do actually have a few myself that I thought we could kick off with. And there's one that's directed at both of you, and I wanted to give you all a chance to, expand a little on what you've said in your presentations. And we at SARAVYC have been involved in a number of projects that reflect the center's commitment to enhancing youth youth protective factors, of course. And I think especially of our Taking Pride intervention, I'll put a link to that in the chat in a second, that we run with the McCreary Center Society, of course. But Taking Pride is sort of broadly applicable, right? It's made to reach a larger, less specific population. And I just wanted to hear from both of you, what are the sort of nitty-gritty specifics of tailoring a program to cis queer girls that you needed to pay special attention to, or perhaps you found in the focus groups to be surprising that you hadn't anticipated? So I'd love to hear from both of you on that.
Wally, do you want to talk about things that you found sort of surprising in the analysis that you were doing that might be specific to lesbian and bi girls?
Yes. So I think for the researcher and clinician perspective, I think creating a very safe space for sexual and gender minority and the girls we in our studies is very important. Like our study show, some people they might not be able to directly share their sexual experience, and particularly for some racial group they would like to share, but for other racial group they might not. So we have to create a space, and also for many people, they might concern about confidentialities, even though they really want to be authentic and share their stories to you, but they have a lot of things to worry. Maybe in the interview, if in person, or if they have to go to the centers, they have to come out. And also they might worry how other people judge them, or maybe their parents or their teachers might know their identity or their status. So I think safety and confidentiality is very important for this population. Yeah.
So as we were developing this intervention, I think one of the important considerations is that we're still talking about the same kind of behaviors that physiologically can put one at risk of sexually transmitted infections or pregnancy. And so how do you make pregnancy prevention queer focused for girls who are into girls? And so a key part of what we needed to do was pay attention to language, and that included focusing on not assuming that when we're talking about sex, that it was automatically sex with guys. We actually got some feedback around maybe using the word sex with a penis, and just sort of being aware of those kinds of specific things. It was also really critically important in this that we were paying attention to sexual health and sexual pleasure and sexual behaviors with girls, or sex with others who have bodies like yours, because a lot of the young women in the online focus groups told us that, you know, they'd gotten teen pregnancy prevention sex ed in school. Okay, a lot of them didn't because it was abstinence only in the United States, but a lot of them did, but they were like, oh yeah, this is heterosexual stuff, and they just like tuned out, and nobody was talking about how you have sex with girls, or what that might look like, or what does pleasure look like, or, you know, the number of young people in our focus groups who were like, I didn't even know what a dental dam was, or I didn't even know that I could get an STI from a girl. And so like this information helped them both make informed decisions about their relationships, but it also gave them, they talked about this at the end, you know, that it gave them a sense of trust to be able to bridge to that other information. So talking about queer girls' relationships and queer girls' experiences and pleasure with the variety of gender partners made it relevant, so that when we did talk about using a condom on a penis, people were tuned into that. And when we did talk about the reasons that young people said that they might be involved in pregnancy and why you might want to pay attention to some of these contexts and issues, was important because they already had heard, okay, these people get it and they understand my experiences. And I'm already chatting with another text buddy who's a girl like me, and we've got similar experiences we can talk about. And that was important, to be able to make sure that we had the credibility, that we understood all those experiences while still being able to say, and the condom goes this way, and make sure this, and if you want to get tested, here's where you go, and those kinds of things. So part of it was a lot of very similar sexual health education, but some of it was very queer specific. And we needed to do that in order to be able to actually provide information that was also queer specific, because just because you have sex with a penis, if you're bisexual, that is not straight sex, trust me. Yep. So that's, you know, an important piece of this in terms of what we needed to do. We also needed to pay attention to language, because I don't know about you, I'm a grandmother of teenagers. I am clearly not in the right zone for the right kind of language to speak for 14 to 18-year-olds today. And so hearing them say things or write things in their words and using their perspectives was absolutely critical to make sure that the message is connected.
Yeah. That's wonderful. Every time, every intervention and thing I learn, as I'm a little new at SARAVYC, I'm like, man, I wish I'd had that when I was younger. So as an American who did the abstinence only sex ed, but we do have a question from Shams. Shams asked to ask it on mic. So go ahead, Shams.
Hi, thanks Dr. Wally and Dr. Elizabeth for sharing your perspectives on the project that you've been working on. I'm fascinated about the projects, and I hope these projects would have the possibilities to be implemented in other parts of the world. And so Wally, I have one question for you, and maybe I have like more than a question for Dr. Elizabeth, so sorry for that. So Wally, yeah, and maybe you have mentioned it, but I missed it while presenting your presentation or your work. So you have mentioned something like the older teens were able to share more details about first time sexual experience compared to the younger ones. Am I right?
Mm-hmm. Yes.
So I'm wondering if those focus group had any, I don't know, some sort of follow-up questions to give us an idea. So why the younger ones were not able to share those details? Where I'm wondering where they have had like less power into experience the first time sexual experience, and the older ones actually were pushing them to do that. Like, I'm just wondering. I'm not sure if you have covered that.
Yeah, thank you for these questions. So I think there might be two reasons. Like as we said, we need to pay attention on their language. So the younger and the older participant, they probably have a bit different language ability, or they probably have different ability to share their stories, even though it happened maybe just a while ago, few years ago. So I think language ability is first. And also some people might need time to process the experience. Maybe some people feel is shame or some stigmas they need to time to process. For a bit older youth, they might have longer time to process, so they might have more contact to share or less worry to share. So that's what I thought from start.
Yeah, makes sense. Thank you, Wally. And moving to Dr. Elizabeth's questions, I will try to summarize them. So, and my apologies if I mentioned that, if you mentioned that within the presentation. So, going to the RCT, so you have experience. So you have mentioned that as a phase 1, there was like online focus groups, and then the RCT as a second phase or third phase, the RCT or the intervention happened. I was wondering about the participants who joined the RCT. Were they all experienced or non-experienced youth?
So recruiting the participants in the RCT, we use the same kind of online Facebook ad recruiting, and they could be either sexually experienced or they could be inexperienced, either one. And in fact, about 2/3 of them had not been sexually experienced with either their same gender or different genders. So, so the majority of young people who participated and who signed up and were recruited actually did not have sexual experience. Over the course of the intervention, some of them did become sexually active, and we did see in the 1-year follow-up from the end of the intervention, we also saw some people begin to be sexually active, and so that was captured in the survey follow-up and outcome data that we got as part of that analysis.
So do you, based on your experience, do you feel this, the insight that you have just shared, is it related to the outcome that you just shared, that there was not like statistically significant reduction of pregnancy rate, since actually 2/3 of the group, they were like sexually not experienced, and then so it makes sense if we did not see any reduction in the rate of the pregnancy. I'm not sure if it makes sense.
Yeah, so part of it is that there was a very small number of people who had been pregnant before the intervention started. 3.5% is, you know, when you think of almost 1,000 girls, that's like 30 young people, sort of evenly divided between the two groups. But over the course of that 20 weeks of intervention and then 12 months of follow-up, there were some young people who did get pregnant, but it was a very small number. If I'm remembering correctly, it was like 4 or 8 in the control group, and then about half that many in, or a little bit less than half that many in the intervention group. So looked at in terms of just like the raw numbers, it is fewer. And so for a randomized trial, that's useful to know. The effect size was a 0.43. So, you know, 60 or 57% reduction in the odds of that occurring. But because it's such a small number, the stability around those estimates is, there's just not enough power. We anticipated that if we'd been able to follow longer term, or if we'd had an even larger RCT to start with, which this was a multi-million-dollar project, and almost 1,000 girls to actually participate is pretty huge as a randomized clinical trial. You know, it's possible that we would detect a significant difference, but it's important to remember that even if it's not statistically significant, it is a clinically meaningful result. And more importantly, the increased numbers of protected sexual acts and people on birth control suggest that long-term pregnancy prevention would be high.
Perfect. And my last, sorry, yeah.
I'm so sorry, but we're gonna, just out of respect for people's time, we're actually gonna wrap it up. But I will say I put our email in the chat, and if we have questions, we can also answer them on social media. So please keep your eyes out for that. I really quickly just want to share an easy way to register. There's a little QR code there for you in case you want to register for the 2 events that we have coming up. And I want to thank you all for spending your lunch hour with us, or if it wasn't your lunch hour, you know, your evening or mid-afternoon. And thank you so much to Dr. Saewyc and Dr. Lin for giving us their time today. So thank you all, and hopefully we'll see you at our next one, which is next Wednesday at 12 o'clock. So
Thank
Thanks,
you.